So let's take this a step further because one of the biggest challenges that counselors face is determining when substance use is crossing the line into being a disorder. Not everybody who drinks or uses substances has a substance use disorder. So it's important that we are not over pathologizing the behavior. But at the same time, we don't want to minimize the patterns that are clearly problematic. So where is that line? That's where the diagnostic criteria comes in. Substance use disorder is not defined by how much someone uses or even how often. It's defined by the impact of that use. So we're looking at things like loss of control or continued use despite the consequences, the cravings, the impairment in functioning. Somebody can drink occasionally and not meet the criteria, while somebody else may drink less frequently but still meet that criteria because of the consequences that are tied to that use. So that's why your clinical judgment matters here. You're not just counting behaviors, you're interpreting patterns. And understanding that addiction is a disease is going to help you recognize that these patterns are symptoms, not just choices. So I want you to think about how often people are minimizing their use. Like, oh, I only drink on the weekends, or I don't use every day, or I'm a social user. But when you dig deeper, you're often finding the consequences, the failed attempts to stop, the significant cravings. And that's where the disease is showing up. This is not about labeling. It's just about identifying who needs to be treated. So there are some core indicators that help us identify substance use disorders. Loss of control might look like somebody intending to have one drink, but then ending up having several drinks, or continuing their use despite the consequence could mean like legal issues or relationship problems or health concerns that don't stop the behavior. Cravings, they're not just thoughts. These are very intense urges that feel overwhelming and difficult to resist. And I often liken it to being outside on a hot day and that urge that's so overwhelming to drink a cold glass of water. Impairment, that kind of shows up in work or school or maybe your family life. So what I want you to notice is that none of these are about morality. These are about functioning. That's another reason that the disease model is so important, because it's shifting the focus from what kind of person is this to what's happening with this person. So as we're thinking about our clients, how many of these indicators do you see regularly? How often are these clients minimizing or denying them? Our role as clinicians is to gently bring awareness to these patterns without creating defensiveness. And that takes skill, and it starts with you understanding. So let's connect this to the brain, because that's where the disease model really becomes clear. Addiction's not just about behavior. It's about changes in the brain's functioning. So when somebody is using substances repeatedly, it's affecting the brain's reward system and their decision-making processes and their impulse control. And that is why people continue to use even though they know the consequences. The brain is literally wired to prioritize the substance. That doesn't mean that they have no responsibility, but it does mean that their behavior is being influenced by something deeper than just choice alone. So as counselors, understanding this is going to help us move away from frustration and move toward curiosity. Instead of asking, why don't they stop? We're going to start asking, what is happening in their brain that makes the stopping so difficult? That shift is going to be powerful because it's going to lead to better interventions and more patience with our clients. And we're going to be able to have more realistic expectations for them. And it's going to help us explain things to clients in a way that's reducing their shame. So when clients are understanding that their brain has been affected, they're often going to feel relief, like there's an explanation for what they've been experiencing. And this is a key mindset shift that I really want you to sit with. Behavior is a symptom. The lying, the minimizing, the relapse, the impulsivity, they're not character flaws. They're symptoms of the disease process. It doesn't mean that we excuse harmful behavior, but it does mean that we understand it differently. I want you to think about how that changes your response. If a client relapses and you see it as defiance, your response might be frustration or confrontation. But if you see it as a symptom, your response might be assessment or adjustment. What changed? What triggered that? What support is this client missing? It doesn't remove accountability, it's just reframing it. And that's what's effective, and that's what counseling requires us to do. So I want you to think about a behavior that typically frustrates you in clients, and then ask yourself, what if that's a symptom? How would I respond differently? And that's where clinical growth happens. I had a client yesterday, actually in group, who kept interrupting me repeatedly throughout group. And we're going to have those types of people. But I was getting more and more frustrated every time he did it. And it was very apparent that he did not agree with having to be in the groups. He was court ordered to be there. And I thought about it afterwards. And I remembered a client who blatantly told me, I have ADHD. At the very beginning. And then as we were going through our sessions, he continuously interrupted me. And the more I became frustrated with him, I stopped myself. And I thought, okay, he does have ADHD, and this is a symptom. This is not him being defiant. This is not him purposely trying to irritate me. This is literally a symptom of something going on with him. So when I reframed that, I was a little bit more patient with him when he interrupted, and I was able to redirect and redirect and redirect with way more patience going forward. And the treatment changed. So I want to talk about stigma because it plays a huge role in addiction and recovery. Stigma can come from society or family or systems or even from professionals. But one of the most damaging forms is internal stigma. When clients start to believe their negative messages about themselves. And when someone sees themselves as weak or hopeless or broken, whatever, it's going to be much harder to engage in recovery. And so that's where your role as a clinician is going to be critical. The way that you talk about addiction can either reinforce that stigma or it's going to reduce it. Even just the subtle language choices matter. Saying, are you an addict or a person with a substance use disorder? Which one is going to reduce the stigma or which one's going to increase it? Are you focusing on behavior or identity? And these may seem like small things, but they're adding up. The clients are noticing. And when the client feels judged, they're going to shut down. And when they feel understood, they're going to open up. That's the difference you can make. And language is one of those powerful tools that we have as a counselor. Person-first language puts the individual before the condition. So instead of defining someone by their substance use, it's acknowledging that they are way more than that. And that's helping to reduce that stigma and support their dignity. But it's also aligning with the disease model. Because if addiction is a disease, we wouldn't define someone solely by it. We don't call someone a cancer. We say that they have cancer. So we don't want to say that you are an addict. You have an addiction. That same principle is applying here. So I want you to think about the language that you're using regularly, not just with clients, but with colleagues and in documentation. Is it reflecting the disease model, or are you unintentionally reinforcing that stigma? This is kind of an area where small changes can have a really big impact. And as someone in a leadership or a training role, the language that you model is going to influence other people as well. So before we wrap up lesson 1.2, we need to talk about something that often gets overlooked, and that is your own bias. Every counselor is bringing their own beliefs, their own experiences, their own assumptions into that room. And it's not a bad thing, but it is something that we need to be aware of. If you've had personal experiences with addiction, that is going to shape your perspective. If you've seen certain outcomes repeatedly, that is going to influence your expectations. The key is not to eliminate the bias, but to recognize it. When you become aware of what your own bias is, you can prevent it from negatively impacting your clients. And when you're not aware, it's going to show up in very subtle ways. Maybe you're more patient with some clients than with others. Maybe, you're assuming certain clients are more motivated, and those things are going to matter. Self-awareness is going to be, it's a clinical skill, and it's going to require ongoing attention. So I just want you to take a few minutes and reflect on this honestly. What beliefs do you still hold about addiction that might not fully align with the disease model? Maybe you believe some clients should know better. Maybe you feel more frustrated with certain types of substance use. Maybe you notice yourself feeling less hopeful with repeat relapses. Whatever's coming up, just write it down. This is not about judgment, it's about awareness. And the more honest that we are, the more effective we're going to be as counselors. Growth doesn't happen by pretending that we have it all figured out. It happens by being willing to examine ourselves. And we need to take this seriously because the work starts with you.